We're live. Sorry about that. Little delay, but we are now live.
Great, we're live. Yes, I can see that. Well, hi, everyone. Thank you for joining us today on this very important conversation. I am beyond grateful that Dr. Pedro Blandon has joined us today. And as you all know, El Paso has made the national news for a terrible reason again, and that's for our COVID hotspot numbers. A lot of people don't understand how serious the problem is and how serious and widespread of COVID is in our community. And that includes our current mayor, DeMargo. It includes our city representatives, Sam Morgan, Claudia Rodriguez, Isabel Salcido, and Cici Lizárraga. And you can see their votes on city council and the fact they haven't really put forth a plan to combat this illness. It's undeniable that our hospitals are at capacity, that our ICU beds are at or capacity, and that our funeral homes and morgues are at capacity. And so we wanted to have this conversation because, as you all know, a recent video by a traveling nurse went viral. And there were a lot of allegations made in that video. And we wanted to give a doctor who is familiar with the situation in El Paso and who's from El Paso and has been here since the pandemic and prior to the pandemic to give us his perspective on what's really going on and to demystify and clarify some of those issues. So I do want to note that Dr. Pedro Blandon is a father of one of our staffers from the mayoral campaign, Graciela Blandon. And I, again, want to extend my gratitude. I know that you're still working, doctor, and I appreciate the time that you're taking right now to help us inform and empower our community. Thank you for being here today.
Thank you, Ms. Veronica. I want to also congratulate you on the recent campaign results. We were just talking how important the grassroots movement that you started, and we were pleased to, become involved and also learn so much about the way the political, wheels move in our city. I want to disclose as well that today all my opinions are personal. I am employed by HCA Del Sol Medical Center. I am the program director for the internal medicine residency. That means I train the doctors of the future. I have been training internal medicine physicians first at Texas Tech since 2009, where I worked there for 6 years until 2018 when I left and came to this position to open this new program. It's a new community-based training program. Many people think that only Texas Tech is the only place for training, but we do have residency training at William Bowman Army Medical Center. They're also training physicians, and Del Sol just opened this new internal medicine residency. We also train transitional year residents, which means they are with us for 1 year and then they move to do their subspecialty in other things like radiology, dermatology, physical rehab, physical medicine rehab, anesthesiology. They have to have a year of what we call transitional year. They rotate through the different specialties. So in other words, I am very close to the trench lines, if not in the trench line myself. I'm training the physicians that are dealing with the bulk of the COVID-19 pandemic, and definitely very much aware and interested in all the sort of behind the curtains, if you will. Initially, we are physicians. We are trained to be doctors, to train one patient at a time, and sometimes we kind of close our eyes to the bigger movements that have to take place, political action committees, and all the strategies that the government has to take to improve our medical care. Because the physician has to also be given the tools to provide what we know best, which is the physiology, how the human body works, and things like that, right? Absolutely. But anyway, with that being said, I'm happy to entertain your questions and give our perspective from what may be happening right now.
Thank you, doctor. Thank you. And you are a nephrologist, correct? And that is a kidney doctor?
Right. Nephrologists, we had to be internal medicine physicians first. I did my training at Texas Tech as an internal medicine physician from 97 to 2000. And from there, when I finished my internal medicine training, I moved to Albuquerque for 2 years to become a nephrologist. But since 2002, when I graduated, I've been practicing both internal medicine and nephrology. And that's why I have, I will say, a unique perspective, because I can tell what the primary cares need, and I can also give a deeper, information on people that are more, they're usually sicker. Nephrologists deal with the sickest of the sick, which is the dialysis patients. We take care of all the most difficult diabetics. Our dialysis patients are by definition the ones that have the most medical conditions, including hypertension, coronary disease, immunosuppression, you name it. Dialysis patient is an example of that. And that's why they're considered high priority as far as vaccinating and all that. So, that's what we try to teach, try to give the different, perspectives for different kind of patients.
I see. And so would you say that, as you've explained this in light of COVID, that you have had the opportunity to be aware of what's going on with the ICU COVID units, especially like at UMC, as opposed to a pulmonologist or an ER specialist?
Right, exactly. We get consulted when the patients are sick. One of the extreme cases of COVID has a spectrum, and I think that's one of the problems. COVID can be a mild situation, but in some cases it will come really hard and very severe. And that one involves the kidney is one of those conditions. That's when the kidneys are affected by COVID, the prognosis becomes really bad. And I have been consulted multiple times. UMC, I lost some of my patients to COVID at UMC, and I've been in the infamous pit, like we talked about. Basically, what the pit is an intensive care unit that had to be created because we ran out of ICU beds. The ICU beds were capacity were full. So there was this place where we do usually endoscopies at University Medical Center. Imagine a big hall where people are recovering from an endoscopy. They have these beds, one next to each other, no division between the beds. There's like 15 or 20, of them in that single hall. And what University Medical Center decided was because there was a shortage of beds, we put all the patients that had COVID in that place. They are, at the end of the situation, they're all infected, they're all positive. So there's no risk of passing it to each other because they're all positive. So the people that work there are the sickest of the sick because they're all the ones that are connected to a ventilator machine. And the nurses that are working there, to me, are heroes because they're really at the bedside, dressed up like an astronaut, covered with gowns, with shields, with gloves, and when they're there, they're like, no rest. You have to really rest. You have to really take a break and go out and breathe without your mask and places that are safe. But when you're there, you're basically inside this bubble that every potential things you're touching can be infected or pass it on to you and so on. So it's really commendable, the work that the ICU nurses do. And I understand how this young lady that published that viral video, she was probably frustrated from working such a difficult situation, hard environment. And basically seeing your patients die in front of you is really frustrating for all of us, not just her, all of the physicians, residents. We had to do debriefings and we meet regularly to help because there have been cases where physicians are committing suicide. At least 2 doctors were reportedly, depressed. Committed suicide in our network in Austin. So it's something that we're constantly reviewing with our residents, make sure their wellness is there, that they're not burned out, the fatigue, the hours that they work, no more than 80 hours a week, or watch very closely. And thank God we had the support of physicians that came out of the, thanks to the state of emergency declaration. We got doctors that are sent to us, they're FEMA doctors, nurses that are currently in the city helping us.
What is Well, we're going to get into some of the infrastructure issues in a second, but I wanted to also ask you, these are all questions that came in through our community, and so we wanted to honor that effort by our members. And so one of the questions was, are you concerned about retaliation? And speaking frankly today, are there any hospitals that you have admitting privileges at that you are concerned about them misconstruing what you're doing today?
No, I think, at this point, like I mentioned, I'm employed by Del Sol Medical Center, HCA, but as a physician, I practice in all the hospitals in town. I start my rounds at Sierra East, and then I come to the highway, Del Sol, UMC. I go to Sierra, Kindred, Memorial, Las Palmas, and basically it's a circle around the city that can take sometimes 55 miles, basically, and starts in the morning and ends up in the afternoon. And we stop in every hospital. And I don't have any concerns as far as my job or any other retaliation, as you say. Again, my opinions are personal because I don't want to, violate any policies of they're people that are public relations, PR. That's what they do for a living. They're professional. They're very diplomatic into the words that they say. And I think in my case, my only limitation is my professionalism, if you will, in the ethics that comes with being a physician. We are all trained from early in our careers to be professionals, to be ethic, to follow certain rules of the trade, if you will. And again, that's really the main limit. Is what is professional, what is ethic. What I'm going to say today is guided by those principles, basically.
Thank you. Let's talk a little bit about medical staff and supplies right now. And I know that you've probably seen a change from March to now. You mentioned that you're trying to limit people from working more than 80 hours a week, which is already astronomical, right? Because this is when they're working. And for them to work 80 hours a week just seems like a lot already. Do you have currently enough doctors and nurses?
Yeah, for example, at Del Sol, we have 45 residents, 45 doctors. There's 15 per class. Every year we have a new class. So we divided into PGY1s, which are also known as interns. They're the first years. The PGY2s and the PGY3s, which is the second and third year residents. We call it senior residents. The 2 and 3s are seniors. And there's usually a team composed of a senior resident and 2 interns. And I can tell you right now that we have teams that are actually double in their size. We had to pull people from rotations that were, let's say, elective or outpatient. Let's say somebody that was doing, I don't know, dermatology or endocrine, something that is not as critical at this point, and they were pulled to the ICU to help the team take care of the overflow. That being said, like I mentioned, we have doctors that are coming from other places. Right now, we have people from the military doctors. I have a rheumatologist running the tent hospital that is placed in the outside of Del Sol. And we have doctors that are coming from Austin, from different places where our company pulls from. They call locums tenens, locums doctors that come in and they help. So every night we have at least 2 attendings that are taking care of internal medicine patients with their team of residents, and also an ICU doctor. We have 2 ICU doctors at night that are controlling the intensive care unit, which are a welcome addition. We need it very much so to help the situation.
Okay. But I'm sure you would welcome even more help.
Yeah, in this case, the more is the merrier. And the hospital has taken a lot of measures to request that help. Every morning, you can see a couple of buses parked in front of our hospital. They're bringing the traveling nurses, the traveling doctors that are living currently in hotels and houses around the city, and they're brought to our hospital by bus. Mm-hmm. And I can tell these are two large buses that are coming every morning to help us with the staffing. And every hospital is doing the same. UMC is also in the same boat. I walk into the room, in the halls of the hospital, I see a lot of new faces, people that are from other places. You can tell they're not from El Paso. But it's like an airplane. You walk into a cockpit of a jet and you find people that you never work with, but we all know what we need to do. So, by following our rules, our protocols, our guidelines, everybody goes to work, and we know what we need to do.
Great. That's great. Now, in terms of, and you may not know this, what about janitorial staff? Is there enough staff to keep this?
Oh yeah,
sanitized?
that is so important. I have actually stopped our housekeepers, our janitorial staff, and thank them, because, to be honest, they are the ones that are making our hospitals clean every time when there is a new patient comes in. They clean those rooms super nice, super well. And so these ladies, this people in general that are working night in, night out, day in, day out, I really, really appreciate their work. And I make a point to thank them when I find them in the halls, because they need to know what they're doing is meaningful. A lot of the times that we say, well, nobody's thanking us, nobody's saying anything, nobody's appreciating the work we do. So I think part of the suggestion I will tell everybody today is thank everybody as you see them, because you never know. These people can be as humble as a housekeeper, but that's, super important. The maintenance people. I mean, they had created in the emergency room at Del Sol, you can walk and you can see how the construction has divided the compartments of the emergency room are now divided. We had the COVID side, the non-COVID side. And this can only be from construction workers that are putting walls, that are building, and that's what the physicians. I mean, it's a team effort. It takes a village to take care of this. Absolutely. So it's very important. Yeah.
What about the personal protective equipment, the PPE? Do you all feel that you have enough of it? Do you need more of it?
Yeah, that is always a problem. I remember when Ebola virus was supposed to come into the city, we were so scared, because Ebola is so much more lethal virus in the way that even a little touch can contaminate you, and from that it can infect you. So Ebola require a super effective protective equipment, like hazardous, type of suits and things like that, completely covered. Thank God, in this case, coronavirus requires a gown, a double mask, which requires, we use the N95 first, which is a very tight mask on our face. So you may see the videos of people showing marks on their faces from wearing those masks for several hours. Mm-hmm. And then we put this mask on, the third level. This also is because the N95s are not splash proof. N95s are only for the air, for the particles, the droplets. This, on top of that, protects a splash. Mm-hmm. I was in a room the other day where the patient was a COVID patient. It was my dialysis patient, and he was not wearing the mask. And I walked into the room and said, "Hey, put your mask. You're gonna give me the disease, right?" Joking, "Hey, don't give me your bug." And he put the mask on like 2 minutes after he sneezed, big time, big, strong sneeze. That sneeze, if I had been in the room with him and he had not the mask, that sneeze, imagine the particles going in the air, droplets going on my clothes and everything. So I'm glad that I gave him I told him, look, put your mask on. And sometimes we're light and telling people we don't want to get in trouble. We go to the grocery stores, at Walmart, we see people with their mask, in the mouth or not in the nose. We don't realize how a sneeze can, and you've seen it because you've seen those videos. So you can see the droplets, how they can spread in a room. And that's why COVID has to do a lot with how long you spend in the room with the patient, right? You can spend, if you spend more than 10 minutes with the patient in an enclosed environment, breathing that aerosol, we call it aerosol, those particles get into our system via our airways, right? So that kind of brings me to the point that one of the things that the lady in the video said is that we are not bagging the patients when they're in CPR mode. In other words, these patients are connected to a ventilator machine, but when they go on a code, the tradition has been to disconnect the machine and put the bag, we call it the bag, the ambu bag, which is that air, provides the air to the patients. When you do that, when you disconnect, that air comes out and is aerosolized. So you could infect somebody and all the crowd that is doing the CPR to you. So that's why these protocols were put in place, not to disconnect, not to bag the patient, but leave them on the ventilator, because the ventilator is a machine that is a computer that is delivering the amounts of air that the patient needs at the right pressure, at the right frequency. So you don't get any better than the ventilator. I mean, unless the ventilator is malfunctioning, which you can tell because the alarms are going off. But if the ventilator is working well and is providing the amount of air at the right pressure, at the right amount, it will never be better to bag a patient. Because the bag, it depends on how strong you push. You know, sometimes you stack too much. You're doing this one after the other, and you're bagging. You're basically inflating the patient to a point that can blow up. So that's one of the things that also we need to explain to the community. It's not that we're not bagging because we're not doing something to our patients. We want to make sure that everybody knows that we're doing the best that we can, and all the protocols that we're following had a reason. We're learning about this disease as we go, because we didn't know about it. But with this kind of concepts in mind, that can be explained. But again, if this young lady was not aware of this, maybe why she went in to say, oh, these people are not even bagging our patients. So it doesn't mean, bagging doesn't mean put them in the bag, right? Bagging meaning that we're not doing the bag with the ambu bag during the CPR.
So bagging is a manual form of providing right. Air to someone versus a ventilator. Okay.
Yeah, the ventilators are the best. And to be honest, that's why they were asking even the president, you know, how many ventilators do we have in the country? Right now in El Paso, we have around 500 beds with capacity for ventilators in El Paso. And so we increased big time. We used to have only 300 beds of ICU. We have increased it to 500 and even more now that we have the convention center. The convention center does not take ventilator machines. When you have a ventilator, that requires a very tight control, because that too can come out of your airway and be moved just a simple movement can be out of a place and requires somebody with experience to put it back in. It can malfunction. So anybody that's on a ventilator has, by definition, to be in an intensive care unit. Yeah.
I see. And right now, do we have enough ventilators?
Yes, we do. They order them at the beginning in March, and we have a full room in Del Sol, for example, where the whole room is full with ventilator machines. And every hospital has their basically reserve and stash of ventilators. Sometimes the problem is the staff, the physicians or the nurses, the respiratory therapists that need to be with them. I remember one night, that was a couple of weeks ago, when the respiratory therapist said, this is the last ventilator we have tonight. So there was a night when we ran out of ventilators. But that being said, we ordered more the next day, and we had that solved. But that can happen. We basically ran out of resources, and we had to basically we call the hospitalism and we defer the care. We send them to a different hospital. We refer them to a different level of care, to another hospital, so on.
Okay, thank you. We have a question from someone regarding the bagging. If bagging isn't necessary for patients on ventilators, why is it ever done at all?
Well, again, it's a routine when people fall on a code situation, CPR, that you have to rule out what's going on, anything that may be happening. And so one of the things to rule out is perhaps maybe a pneumothorax, where there is high pressures inside the system, and they blow a lung, and the lung is completely collapsed inside the chest. And so we disconnect to allow for that in the past again. But like I said, they usually are all the ways of measuring or checking for that. We examine the patient, we listen. We also look at the trachea, if the trachea is central, if the trachea is not deviated to one side, then we can tell there's a pneumothorax or not. We look at the pressures in the machine and the ventilator, and if all the pressures are okay, then there's really no need to disconnect. But when in other situations, when the patients need to be coded, or we call it code when somebody's doing CPR and reanimated. Yes, in the past we have done that. We have disconnected the ventilator to make sure it was not the vent causing the problem. Yeah.
So at this point, is the risk of infecting the medical staff one of the factors that you're considering in not doing the bagging?
Yeah, I understand. Again, that's from the intensive care unit physicians call those decisions, right? Every case is different. Every case is different. That's another thing you have to explain to people, that every case we deal with in the hospital, there's a different set of conditions. We don't treat everybody the same way. Everybody has a degree of lung problem or lung disease. And as I was discussing with other people that asked me the same question, when you have a patient, let's say it's completely their lungs are completely damaged. The coronavirus can affect. When we see those X-rays are completely white. Usually you can see a dark column of air, but when they have coronavirus, they look white. They're white out, and we are giving already maximum oxygen to these people, 100%. Pushing the air with pressure, and with there's really nothing else to do, because the oxygen cannot be absorbed by the lungs anymore, because the lungs are wiped out. What are the chances of this person to recover if they fall into a cardiac arrest? Basically nil, 100% mortality, right? But that being said, the family still wants everything done. Family wants keep at it, keep doing it. Keep they say keep all the treatment, full code. We call it full code, as opposed to do not resuscitate or do not intubate, which is what we call DNR. DNI. Many times we call the family and we say, you know what, your patient is so sick that we recommend that perhaps we should not resuscitate if he goes into cardiac arrest. But again, the family, being loved ones, they don't understand medical terms. They say, no, doc, keep going. It has to keep going. And we as physicians, we will bring the topic every day, every time we discuss their loved one's condition. It's a tough and draining discussion. I can tell you that it's not easy for a doctor to be telling family members over and over again, your patient is not doing well, you should perhaps stop here, and because we're not gods, we cannot recreate life. We're not gonna, there's a limit to what we do, and the body will tell us when we have reached our limits. We provide the ventilation 100%. We give pressure. We give all the treatments, all the medications that we have on our armamentarium, and the blood pressures are dropping. The heart rate is not wanting to, beat the right amount, the right frequency. That means the patient goes into cardiac arrest. And so what do? We do CPR. And yes, we'll do CPR to see if there's a hope, a glimmer of hope in this patient. But I can tell you that probably that statement of that visiting nurse was correct, in the sense that there's many times, and after a couple of cycles, knowing that the patient is so sick that there's no point in us continuing CPR, because it's a futile treatment. We call it futility. So when it's futility of treatment, there's no point in us continuing doing massage CPR for a whole hour, because we know those lungs are completely gone. And so that's what it's a call. It's a call that every physician has to make. And it's a tough decision, but I can assure the community and the population at large that we are doing all that we can. When there is a hope, we continue pushing. And when we find the signs of futility, we see that the situation is not progressing, that patients are there for weeks at a time and they're just not moving, not getting any better. We talk about family, to the family about life withdrawal and so on. So that's the human component of this tragedy, because many times those family members are not even in the room. They're like from home, they're over the phone with the video. We set up the iPad or the telephone for them to be watching their loved ones. But it's one of the things that really impacted me, is to to see these people die in front of us with no family members around.
Yeah, absolutely. And this brings us into the topic of rationing, right? So rationing is when the demand for medical equipment like ventilators is greater than the supply of them. And medical staff has to decide which patients will get access to that equipment. And there was an article that one of our supporters posted or shared with me that I'll post later. And most state health departments have rules and guidelines for healthcare facilities during disasters, including running short of ventilators during a pandemic. And so, for instance, in Alabama, there's a statement that was made about, when we have a mass casualty disaster like a pandemic, it may necessitate that commonly accepted standards of medical care are altered to provide the maximum number of patients the best chance of survival. So basically, you're asking who is worth saving when we don't have enough supply of equipment. So this was raised in the video that you mentioned by the traveling nurse. And there are concerns, for instance, that people with disabilities are likely to be sent to the back of the line. And has that been your experience in El Paso? Because earlier you mentioned prioritizing people who have what we think of as now pre-existing conditions like diabetes, high blood pressure, kidney disease.
Right. Again, we're learning about this disease as we go, but we can tell when somebody is a high risk, somebody that has a morbid obesity, diabetes, cardiac problems, or also any kind of immunosuppression, like somebody's a kidney transplant. I lost a kidney transplant patient precisely at the UMC, the famous pit. And because they're immunosuppressed, so the virus spreads without any resistance from the immune system and spreads very fast. And as you mentioned, when you have a mass casualty disaster, which is equivalent to the pandemic, we have to triage our patients, and there are guidelines for triaging. And I know it's tough, I know it's hard, but this is where the community has to get together, and we form committees in the hospital where in a situation where there's a shortage of ventilators, for example, somebody that has poor prognosis may be not the right candidate to be put in a ventilator, and we'll go for the people that have more potential to recover, the younger, the ones that have no diseases. And there are issues where even the own patients will say, don't, like I've seen the testimonies of older ladies, like an 85-year-old lady, don't use the ventilator on me, doctor, use it on somebody that has a hope. That being said, I think that patient recovered, thank God. But there are situations where even the patients will tell you, I don't want to be intubated, use it on somebody else. Well, we follow those rules. There are examples in different books and the literature. I can guide the public to read what we call ATLS, Advanced Trauma Life Support. This is a book that tells how to deal with the mass casualty and how to triage patients in different situations. And they, for example, give an example of somebody that has burns, 100% burns in the body. That person is going to die no matter what we do. That's somebody that you can basically provide comfort measures only, and that's it. So, but somebody that is potentially reversible, salvageable, as we call it, that's the one that we need to give priority. So you walk into a room and you have a whole bunch of people that are sick. You can divide them in those that are moribunds, the ones that are salvageable. But anyway, those are the things as physicians that we have to deal with in every day, and we're trained to do. And you hope that the government helps us with the logistics part of it, because it's not just the doctors, but we need all the logistics. So having a tent outside of the hospital to deal with decontamination, having extra protective equipment, having and so that was a surprise when I was told that El Paso, the city of El Paso, did not have a health department or health director for so many months. since March. And so I think that was not a mistake, but of course, when you look at 2020 retroscope, right? But I think when you deal with an epidemic or of disproportions, we really have to have an incident command post where people are able to request, equipment, information. We had to create a WhatsApp group, with physicians, creating our own WhatsApp group to share the information, because there was nobody really giving us any guidance early in the disease. So we formed a WhatsApp group, and we transferred to each other the real articles that are medically sound, because you're hearing people that are like, oh yeah, use this medication, use this. People are using water peroxide and nebulizations, that created burns in their lungs because they heard that in WhatsApp, or they had it in a video that got to them from some who knows where. People using the air heater, in their nose, because they heard that the heat was going to kill the virus. So they create themselves, burns in their noses and stuff like that. So it's really one of those things that, again, we were dealing with fake news, with politics behind the pandemia. And I only hope that we are all working to the best of our skills and with the professionalism that we need to exert. And that being said, yes, dealing with shortage, with restrictions and equipment, sometimes we have to prioritize, and hopefully the rules and guidelines that can be followed. And there's no such a thing as a VIP patient. Like people say, oh, this is a VIP patient. No, everybody's treated the same. The only thing I can tell you, there is an equipment called ECMO, extracorporeal membrane oxygenation. It's a really a very intense equivalent to being in an open heart surgery, where you connect through a cannula in the aorta or in the big vessels in your legs. All your blood is shifted to a machine that oxygenates the blood in a machine outside of your system, where you don't have any lungs to work for you, because the lungs are affected by the coronavirus. So there have been extreme cases in the bigger cities. We're not Houston, we're not Dallas, we're not Albuquerque. Paso is a mid-sized city. We don't have ECMO. We're working on getting ECMO, but at any point, ECMO is like two machines working at any given time. So you cannot have ECMO for the open population.
And does that increase the chance of survival?
Again, ECMO is a heroic measure. It doesn't warrant survival. It has a lot of complications in itself. The technique, infections, and things like that. So it's not a cure. It's not a complete cure. It's just a heroic measure.
Absolutely. Now, there are some other questions now that are a little bit, in different directions. And I know that you're moving, so we're going to just try to follow you until you, have to go, because we've had you on for a little bit. When do you know right now of data that identifies people who have been infected with a disease more than once?
Yeah, there are cases where people are infected earlier. Let's say they got infected in March or in May, and then they come back a couple of months later. And there's always the concern that, is this a new coronavirus infection? Many times what we're dealing with is the sequela of the coronavirus. The coronavirus can leave the lungs in a state of fibrosis, scarring, and that those areas are affected for several weeks, up to 3 months sometimes after the infection. And so we do an X-ray, and we see that infiltrate there on the X-ray, and we don't know if this is a scar tissue from the previous infection or it's a new infection. So it's important to compare, and it's important to test. Now we have done the testing, and sometimes you can find positive testing even 60 days after the previous infection. So it's hard to tell. We're gonna eventually have to move on to measuring vital load, like we have measured for HIV virus. HIV, you have ways of diagnosing. First, you do the antibody test. So the current test that we're doing for coronavirus is really an antibody, or a PCR that detects the particles of the virus. but we like to see how much there is, if there is a viral load positive, or it's just the antibody that is there. So it depends on the test that you're using, and but it's, you know, potential that the virus might mutate also, and you get an infection, a secondary infection with a mutation. So that's why it's important to keep track of all these cases. There's constant research going on right now, and we're only hoping that the vaccine the vaccines that are being created by, you know, the companies right now will cover, as they say, 95% of the population.
See. Do you have confidence in the way the data is being gathered and shared by the El Paso health officials?
Yeah, I definitely trust. Every day I look at the statistics. Dr. Coranza has done a great job with his team. Every hospital has a chief medical officer, and really a shout out here to all the CMOs in every hospital, Dr. Joe Hendricks at UMC, Dr. Alosi at Del Sol, Dr. Oscar Vega, Las Palmas. Every hospital has what we call a CMO, Chief Medical Officer, and they oversee the whole operation. They're the ones who give the statistics. They're the ones who provide us with guidance as far as the new rules of the game and things like that. So we look at them. They're known to all of us, and we know where to look as far as the information is needed. We have to be watchful of things that come from non-trusted sources. Fake news that can spread sometimes too fast. And so whenever I see something that is completely out of character, I want to confirm the source. And that's one of the problems with social media, right? It can be very efficient, but it can be sometimes bad for manipulation of the news, or some people that do it without even realizing the damage they may be causing, the fear. And that's why we had to explain to these people what's going on. If you are sick and you want to come to a hospital, you have to trust your physician. And that's why it's important that you have a primary care physician that you know that is somebody that you have a relation with. Most people say, oh, I don't have a primary care doctor. I've never seen a doctor. I don't take care of myself. I don't exercise. I don't, so this has brought the important issue of health access for all of us. I'm a strong believer that the most powerful country in the world, the United States, has to have access to medicine for all, Medicare for all, or insurance for all, but somehow. And because at the same time, and we have to recognize there's people that appreciate the freedom, they don't want to be pushed to do anything themselves. So you deal with all these people that say, hey, nobody can force me to have insurance. I understand, but at least you have the option. You have to have the options where you can buy a basic insurance, or you can have different levels. But you have to think on the common good. When somebody gets sick, it's not just you. You're affecting a lot of people. You're passing that infection to a lot of people. And so that's one of the things I really preach, is that, please make sure you have a primary care doctor somehow that will know you, that you have trust with, and they will guide you when you need to be admitted to the hospital.
Mm-hmm. It's a very important point. And there has been a lot of talk about comorbidities and underlying conditions, which we've talked about before, and the fact that we haven't really had a fundamental discussion about how to deal with these issues before a pandemic and during a pandemic, for people who don't have access to healthy homes, healthy food, healthy workspaces, healthy physical environments, right? El Paso has terrible air pollution issues that we know impact our lungs capacity as well as our cardiac health. And so having access to healthy spaces is really important. And things like this really highlight the reason that it's so important for us to, of course, do what we can as individuals, but also to ask our leaders to do more in these areas so that we do have access to healthcare and all these other things that will make our health infrastructure's job easier, because you're not just dealing with COVID, you're dealing with so many other underlying issues that are made worse, of course, with COVID. In terms of, we talked about this a little bit earlier, in terms of indoor spaces, do you have a position or recommendations for the shutdowns, whether they be complete shutdowns or partial shutdowns? You talked about exposing yourself to someone for about 10 minutes, whether or not they have a mask, correct? Even if they have a mask, you still want to limit exposure if you're inside. Is that your?
That is correct. I think at this point, until we have an effective treatment or a vaccine that has been covered, at least they say 70% of the population. Dr. Fauci is our expert, national expert, and that's what the recommendation from the CDC are. Until that coronavirus vaccine is used and everybody has the access to it, I think we should limit our exposure in public places and places where you're going to be in an enclosed room. With as many, they recommend for Thanksgiving, no more than 10 people in a room. That's the rule we follow. No more than 10 doctors in a room in our hospital, and our lectures are done on WebEx. We try to keep anybody less than 10 individuals in a room. And so I will suggest that when possible, again, this is a free country and it's very hard to enforce that kind of law. You're not going to have police breaking down in houses because they have more than 10 people, right? It's not enforceable, but it has to be coming from our own conviction that we have to do it for our own sake and for the sake of our loved ones to try to avoid that. There will be other opportunities. The nice thing is that we're resilient. El Paso has been resilient and everybody's resilient in the sense that this is going to pass probably in a few more months. We'll be looking at this as a nightmare in our lives. But so we have to limit ourselves. I will suggest that as much as possible we avoid going in public places. We have clusters in grocery, places like Walmart or Target, or that's been reported because people are just still going. So use all the means to avoid that.
Absolutely. And I think we may have lost him, Casey.
Yeah, let me send a text to make sure it's on, because that was pretty mid-sentence.
May have been maybe battery on.
Yeah, that was maybe a battery issue.
Well, and to everyone who's given us questions, I think we've covered almost all of them. There are a couple maybe that are still unanswered that we'll try to get to. And if we can't get to them during this live broadcast, we can ask Dr. Blandon if he'll graciously answer them in writing, and we can post those answers later. I think that we received some that are a little technical, but very useful, and I've certainly learned a lot.
Right, he's on his way back. I think it was a sudden disconnection. Alrighty. Yeah, okay, admit. There we go.
Awesome. Dr. Blandon, I think you're back. Thank you so much.
Yes.
A couple of questions left. I know that you are at work and doing a lot of things at the same time as you're talking to us, and we appreciate your time. Do you feel that the medical community's voice has been adequately informing decisions by the city and the county?
Yes, at the beginning of this problem, we never imagined. I guess everybody had different expectations about what to do with the pandemic. We saw that was so severe, and the government needed to clear. The president was obviously not disclosing initially. He thought it was going to be a mild situation, but when we started seeing it and living it ourselves, we realized this is so much of a problem, an emergency. And the city received a federal CARE Act, funds to help the situation in our city. So using those funds is important. I understand there were like $120 million given to our city. So the problem is how to use it, right? Do you Do you buy protective equipment? Do you buy a house or a building to house the new doctors that are coming in? And I think that's where the decision has to be made in a community or a committee that hears all the voices of the stakeholders, right? In this case, the physicians, our nurses. I can tell you at the beginning, I was afraid. I was afraid of going into a room with the patient. But now we learn how to do it. We wear our masks, double mask, our face shields, our gowns. Some places you have boots, some others don't have boots to cover your shoes. But of course, the more protective, the better. I wish I could have an astronaut suit with every patient, but I don't, and it's not possible. So we have all these gowns that are, a finite resource. So I just hope that the city supports, and I think is doing it. It's just, again, it's sometimes hard, and sometimes as individuals, we don't understand like that. You can hear from the leadership saying, "Oh, I was not invited to this party. Well, how come I was not invited to the wedding of such and such, or the baby shower of my friends?" And they say it in public, right? So whatever we say in public, when you're a public figure like our mayor DiMargo, you have to be careful with everything you said, because everything you said is an example, and that's why I will see a stark comparison between leaders that wear a mask that don't wear a mask. Again, in this case, it depends where you're at, but in my case right now, I'm in the clinic. I need to be wearing my mask, and I want to project that image to all my residents, my colleagues. Sometimes I'm in a room, and this person, well, maybe eating, maybe drinking a cup of coffee. It's okay, but after that has happened, basically put your mask back on, and protect your colleagues, protect your people. So I would say that it's important that we have a wise use of our resources. The city of El Paso has become, the city, everybody has become important to in the logistics, in the management of this complicated situation. It's not just the physicians, it's who's dealing with the morgues. We have people that, we hear that the prisoners are being used to go to the morgues to help move the bodies, right? Who would have imagined that this was a situation now that has been a public cry out? So I think we need to be involved, be aware what's going on, and use our resources wisely, and have everybody involved. That's my rule. When I have a difficult decision to make, I don't want to make that decision by myself. I call the colleagues, I call the stakeholders, I call whoever is involved. So when the decision is made, it's a collective decision.
Absolutely, as it should be, and it does relieve the pressure from that one person making the decision. We have a couple of technical questions, well, the first one deals with convalescent plasma antibody treatment, and is that an option for COVID patients in your experience?
Yeah, we have used it in our hospital, but the results are modest, if any. It was approved in an emergency. It makes sense, scientifically, but perhaps we need to, synthesize a little more concentrated version of these antibodies. What happens is anybody that got COVID creates antibodies, so we ask them to donate their own plasma, and then that plasma is administered to a patient that is sick. We may not be using the right amount. We may be needing to pool plasma from several people into a package. We usually use 10 donors into a concentrated plasma package. But it has the potential to help. It was reported that it helps mostly modestly in the severity of the cases. The problem with the virus is that it triggers its inflammatory response. It's like a cascade. Once it hits the lungs, the tissue in the lungs dies, and it releases these substances that are like inflammatory. And so it's a inflammatory cascade. And so those dead tissues that you have in your lungs, they can basically become like emboli. They go into your bloodstream, downstream, and they clot the lung. So we have people that have pulmonary embolism. We call it lung clots after the COVID And that's why we got to use blood thinners in our patients. So we got blood thinners. We use, basically dialysis to remove the inflammatory substances of the body. That's one technique has been investigated. But everything is fraught with complications, infections, catheter infections and this and that. So everything is even an aspirin has side effects. So people are afraid of the vaccine, but I would say, don't be afraid of the vaccine side effects. So everything has side effects. Well, of course, we're going to find out when we inject 1 million people, and we're going to find out more things. But so far, the studies have shown that it's a safe vaccine, and we should all get it.
Okay. There's a question about data regarding intubation timing on COVID patients with severe hypoxia.
Right. That is a question that comes really commonly. Everybody thinks that the ventilator is a lifesaver, but we have also found that the ventilator can be a double-edged sword because we're putting air under pressure in the lungs, and the lungs can blow up. So right now, it seems like the patients do much better when you put them on a high flux oxygen nasal cannula. It means still the little tips on their nose that are kind of blowing air at a super high concentrated oxygen level. Or the BiPAP, which is a machine that basically is a mask on our face, and that when the patient inhales, the air is pushed into your airway. But that BiPAP is also, fraught with problems. So sometimes the mask comes off, the patients get very anxious. I have had patients that they basically want to not have the mask on. They'd rather die because they feel so enclosed and so tight. And perhaps somebody their mind is not completely there because they're sick, they're delirious, they're not following commands, they may be demented, and they want to take their mask off all the time. So you have to have a nurse or a sitter right there at the bedside keeping that mask on. So those are the things that come in, but intubation seems to be more of a late. It's better to do it late when everything else has failed, and you already maximize the other options, right? The BiPAP or the high flux.
Okay, thank you so much. Okay, I think that I'm going to take a second to just go through some of these questions, which I think you've already answered. And let me see. There's a question about, let me see. Is El Paso using any types of therapeutics like remdesivir, convalescent plasma, et cetera, or is it purely supportive therapy being provided? If so, who receives these treatments?
Well, we have our basically CDC guidelines. Anybody that requires supplemental oxygen, that means is not able to be without oxygen. And that's the problem. The virus affects your lungs. It takes a while for the lungs to recover. Until those lungs are recovered, you have to be on oxygen. And many times that's what delays the discharge. We cannot send them home unless you have a home oxygen machine. Well, guess what? To have oxygen, you have to have an insurance. Because when you go home, home oxygen therapy costs $170 a month. And so the social workers spend half of their time in their hospital arranging or trying to have a company that will provide this oxygen machine to take home. And that's what takes 2 or 3 days. Sometimes the patients are just sitting there on the bed with oxygen in their nose, waiting to be discharged because there's no home oxygen. And so if I say, well, again, we have the most developed country in the world, how come we cannot provide oxygen to these patients so they can go home and continue their treatment at home, which is the best, because that way you avoid any other complications, right? So I would say perhaps we need to have a standing oxygen company at every emergency room in our hospitals, and have somebody that can do it even at 2 or 3 a.m. in the morning, right? Because many times they come in the middle of the night, and we cannot send them home because guess what? It's 4 a.m. Nobody's going to do that at 4 a.m. So they have to stay in the hospital, and that takes another 2 days to arrange. So if I say, well, what can we do? Why don't we have all the durable medical equipment companies of the city pull in a single place, and provide people with facilities or payment plans, if you will, or some sort of way of having the city paying for those oxygen tanks or those oxygen they call it concentrators. Basically it's a machine that never runs out of oxygen because you plug it at home and it takes the oxygen from the environment, from the air, and concentrates and sends it into your nose. So that's what they call oxygen concentrator. That can be plugged in your household and it never runs out because they're taking the air, the oxygen from the environment. But when you move, let's say you need to go to